Well, hello, pharmacology students. Since we didn't have much time to talk about heart blocks, I thought I would give you a little primer about heart blocks that you could watch and review as much as you wanted to. So to begin, let's review the conduction system of the heart. So here we have the ventricles. Here's the right ventricle. Here's the right atrium and the left atrium. And then below those we have the right ventricle and the left ventricle. So let's go ahead and that doesn't write very well, so let's try something that writes a little better. So there's the left, and here's the right. And these are the atria. Those are the upper chambers. And these down here, those are the ventricles. So remember that the heart beat originates at the sinoatrial node, right here. Now the sinoatrial node is in the upper portion of the right atrium. It's close to the opening where the inferior vena cava empties into the right atrium. So superior vena cava, and here's the inferior vena cava. So about the place where the superior vena cava empties into this right atrium, you have the sinoatrial node. Those are the pacemaker cells. The beat originates here. It then spreads because remember, these cells are all connected to each other. It's going to spread throughout the atrium. It will go from the right atrium to the left through this little bundle here. That is called the Bachmann bundle. The Bachmann bundle and this will now cause these two atria to pretty much contract simultaneously. Once the signal gets down to the bottom of your right atrium, it will be picked up by the atrioventricular node. From there, it will move through the septum. This is your bundle of His. And then move through two different branches, a left and a right bundle branch. These will then swing around the apex of the heart. On the left side, there's also an anterior division, which is a branch of the left bundle branch, which we see here. These then will further divide into the so-called Purkinje fibers. Those will then give the signal to beat throughout the wall of the ventricles, and it will also move into the papillary muscles and what have you. So when we have a heart block, we have different types of heart blocks. The first type of heart block, there's three main types of heart blocks. So three main types of heart blocks. And they're called type 1, type 2, type 3. Not very interesting, I realize, but that's the way they got named. There's two different types of type 2s. As we'll see, there's a so-called Mobitz 1 and a Mobitz 2. Very good. So let's now go to the first type of heart block. First type of heart block is technically not really a block. It's more of a delay. So here is an EKG of an individual with a type 1 heart block. And what I want you to see is that the P wave is quite a bit before the QRS complex. So here's our P wave right here, and here's our QRS. P wave right there, QRS, P wave right there, QRS. This is a delay. The signal to beat has trouble going from the AV node down to the rest of the heart. It gets there, but it takes a while to get there. So we could take a look at some of these others, and we just see this theme. There's a delay. Now, typically, this is your type 1. Type 1s typically are benign. Therefore, they do not require treatment. So again, these are characterized by a delay from the P wave to the QRS wave. So the PR interval is increased. It's consistently increased, as you can see in the EKG up here. So that is the first degree, otherwise known as type 1 atrioventricular block. First degree, or type 1 atrioventricular block. Now let's take a look at a second degree atrioventricular block. Now there's two types of these. Here's the first one. So this is a second degree AV block. This, however, is a Mobitz 1. A Mobitz 1. Now with a Mobitz 1, each atrial impulse takes a longer and longer time to get to the ventricles until eventually they virtually go missing. As you can see right here, you get a P wave and it never gets through. So this is the feature of a Mobitz 1 second degree AV block. So the PR interval gets progressively longer. Until it gets dropped. So the heart will drop a beat, essentially, and you go from a little bit of a delay, a little longer delay, even longer delay, really long delay, heart drops a beat, and we go again. Now this, once again, typically is benign. And it's benign, so usually no treatment is required. So that's a second degree Mobitz 2. The PR interval gets progressively longer. Now let's take a look at a Mobitz 2. A Mobitz 2. So I put this one essentially with a Mobitz 1. Now with a Mobitz 1, essentially, you have progressive lengthening of the PR interval until a beat gets dropped. With Mobitz 2, You do not have progressive lengthening. The P to QRS interval is normal until a beat is dropped. So with this case, the transmission through the AV node is either all or nothing. You usually get a complete transmission of the beat, or you get no transmission of the beat. Now, whereas a first degree Mobitz 1 is usually benign and does not require treatment unless it's causing other symptoms, the Mobitz 2 is potentially dangerous. Now, why is Mobitz 2 potentially dangerous? It's potentially dangerous because you can have severe bradycardia, with that severe bradycardia, you have decreased cardiac output, and Mobitz 2s can also progress to third degree cardiac blocks. So if you don't treat them, they will tend to get worse and go to the third degree cardiac block. Also, you have severe bradycardia, decreased cardiac output, and a third degree is a so-called complete heart block. Complete heart block. And that's the third type. Let's take a look at a third degree AV block. Here you have a complete discoordination between the atria and the ventricles. So if you look at this EKG, you'll notice that you have a P wave that occurs at different times relative to the QRS. Here you can see it almost occurs right on top of it. Here it occurs well before it. Here it occurs pretty much as it should, just before it. Then you get it just popping up here like a jack-in-the-box. Then it occurs in the middle of the T wave. So you have no coordination between the atria and the ventricles. So the atria do their thing, the ventricles will then do their thing. The ventricles recognize they're not getting any impulse, so they respond by generating their own electrical rhythm. This is called a ventricular escape rhythm. And they're doing this more or less to hang on for dear life. Both the atria and the ventricles, in this case, will have their own pacemakers. They now contract completely independently of one another. As you see here, this is called AV dissociation. AV dissociation. So this desynchronization of the heart chambers, it greatly reduces cardiac output. This can lead to syncope. Syncope simply refers to fainting spells. Or, even worse, it can result in sudden cardiac death. So again, the feature of this is that the P waves and the QRS complexes, they have nothing to do with each other. And that is a feature of your third degree AV blocks. And the way you treat this is with a pacemaker. With a pacemaker. Very good. So those are the three things. So what kind of things can cause a AV block? Well, there's actually several things that can cause an AV block. First of all, of course, a myocardial infarction. In this case, you have dead cardiac tissue. That dead cardiac tissue cannot conduct any sort of electrical impulse to beat. Electrical disturbances that alter membrane potentials. One in particular would be hyperkalemia. Hyperkalemia refers to excessive potassium concentrations. So your potassium concentration has to be 3 to 5.5 milliosmoles of potassium. If you're above 5.5, then you have hyperkalemia. We'll see there are some drugs that can do that. So this will disrupt the membrane potential. That can cause a heart block. Then there are external causes. So for example, Lyme disease can cause a heart block, and there are certain drugs that can cause heart blocks. So beta blockers can cause heart blocks. So can calcium channel blockers. And then drugs like adenosine, amiodarone. Amiodarone is a class 3 antiarrhythmic. Has a very long half-life. Difficult drug to deal with. And then another drug called digoxin. Digoxin is typically used in heart failure, but that can also cause heart blocks. Interestingly, a congenital heart block is a complication of neonatal systemic lupus erythematosus. So neonatal systemic lupus erythematosus. If you don't know how to spell that, see me, I'll tell you how to spell that. In this case, you have maternal autoantibodies. And those maternal autoantibodies, these are called anti-Rho and anti-La. Sounds like something from The Sound of Music, doesn't it? These cross the placenta and they attack the conduction system. All right, now, there are also blocks of the bundle branches. Bundle branches. So there's two types of blocks of the bundle branches. There's, of course, a right and a left bundle branch block. So let's take a look first at the right bundle branch block. So the right bundle branch block, you are going to see disruptions in chest leads V1, and then also V2 and V3. Now, why would you see them in these leads? Because those are the leads that are going to tend to give you more information about the right side of the heart. And since the right bundle branch is going to feed the right side of the heart, these are the ones that are going to give you the most information. Now, the V1, the V2, and the V3, as you see, are going to show this kind of sawtooth sort of morphology. This is called an RSR. RSR. So you have a pronounced R wave followed by a deep S wave, and then followed by another R wave, hence the so-called RSR that's in V1 through V3. This is very characteristic of your right bundle branch blocks. Man, that's hard to say fast. So some cardiologists will say that the RSR kind of gives the EKG and the V1, V2, V3 a kind of rabbit ears in the right-sided chest leads. So the causes of right bundle branch blocks might include right ventricular hypertrophy, that can cause a right bundle branch block. You might also have right-sided heart failure, and also pulmonary embolism. And as a study in your vocabulary, I'm going to have you look up the term embolism. For unknown reasons, you can get a right bundle branch block in normal hearts, and that seems to be due to the deposition of fibrous tissue that interrupts the conduction pathway, so that will tend to occur in older people who may not have had heart attacks. So that's something to keep in mind as well. Okay, now let's go to your left bundle branch block. So in your left bundle branch block, your QRS complexes will be wide because of the delay in ventricular depolarization. And then in leads 1 and AVL, and then also in V5 and V6, you will see your alterations. So you're going to see tall R waves, particularly in V5 and V6, but also in 1 and AVL. Tall R waves. And then in lead V1, and then also in V2 and V3 to some extent, you'll see this very deep S wave. And this is the big characteristic. That's the one you really need to remember, is the very deep S waves, particularly in V1. And another feature you'll see, you see it right here, T wave inversion. So you get tall R waves in AVL1, V5, and V6. You see deep S waves in V1, V2, and V3. And then in V5 and V6, you may very well see inverted T waves. And you can see that here too. Now, when you get left bundle branch blocks, they never occur in normal hearts. If you see a left bundle branch block, there's always something wrong with the heart. And what kind of things can cause this? So first of all, there's hypertension. Then there's ischemia. Ischemia means that you lack molecular oxygen. You can also have dilated cardiomyopathy. And then you can have aortic stenosis. Aortic stenosis. Okay, so these disorders affect the left ventricle. They cause a delay in conduction through the cardiac tissue with the changes in the EKG you can see here. And a new left bundle branch block in an individual presenting with chest pain may be sign of a myocardial infarction. Yeah, MI, that doesn't mean Michigan, that means myocardial infarction. Okay, so a quick review. Your AV node block is divided into 3 major subtypes. You have your first degree AV block that is simply a delay. You have a prolonged QR interval. You then have a second degree block that has 2 types, Mobitz 1, and then, wrong one, Mobitz 2. And Mobitz 1 is characterized by a progressively longer PR interval followed by a drop beat. Your Mobitz 2, you have a normal PR interval followed by a sudden drop beat. And in the type 3, you don't have any relationship between the top and the bottom of the heart. And then you have your right and left bundle branch blocks. In the right bundle branch blocks, you have the RSR complex, or so-called rabbit ears, that appear in the right-sided precordial leads. In the left bundle branch block, there are tall R waves in leads 1, AVL, V5, and V6, and the deep S waves in lead 1. And those are your heart blocks.